Go ahead and get started. So you'll see up on your screen, welcome everybody to today's Sarcoma Awareness Webinar. We're really glad that you're spending your Friday with us. I'm Alyssa O'Driscoll. I'm proud to be at the helm of the Sarcoma Alliance as our Executive Director. The Alliance is dedicated to the guidance, education, and support of everyone affected by sarcoma. Sarcomas are rare cancers of the connective tissue and bone. And before I introduce you to our special guest speaker today, I'm going to orient you a bit to the Alliance and our programs. So this is a slide. I'm going to speak first about who we are, including our history, mission, and leadership. And then I'll go into what we do, including our programs and initiatives. And then finally, we'll talk about how to get involved, especially as it relates to July as Sarcoma Awareness Month. I'm going to speak a few minutes here at the beginning, and then our guest speaker will have the remainder of the time today. If you have any questions as we go along, please feel free to post them in the chat, and then we'll try to get to as many as we can at the end of our presentation. So to begin who we are, so our founder, Suzanne Renee Leiter, was diagnosed with synovial sarcoma at a time really when resources and support for sarcoma patients were few. It took her 4 years to find Wendy Summers, who was our co-founder, who was going through a similar diagnosis. The Sarcoma Alliance was born really out of Suzanne's living room, where she was determined to ensure that other people diagnosed with sarcoma would not feel as alone as she did before finding Wendy. So today, the dreams and dedication of Suzanne and Wendy live on through our mission. In their honor, we continue to serve as a resource for those facing a sarcoma diagnosis to ensure they have the guidance, support, and education that they need. And there are a couple of pictures there. And we've been around since 1999. So our mission, the Sarcoma Alliance is a 501c3 nonprofit that serves as a resource for sarcoma patients and their loved ones by providing them with improved access to care, guidance, support, and education on their cancer journeys. While our organization is based in the US, the resources we provide help to inform and connect people affected by sarcoma worldwide. So none of the work that we do at the Sarcoma Alliance would be possible without our amazing team and leadership. Our board members are actively involved in helping us to keep our programs running smoothly. Thank you. Raise awareness and funds, and then connect the organization with new opportunities for growth and partnership. So what exactly do we do exactly? So here is a slide, what we do. So we inform, support, and connect those facing a sarcoma diagnosis with a variety of resources that I'll provide more details on in the next few slides. So information initiatives, we have our quarterly newsletter that provides news and updates, information on upcoming events. We also have a social media Facebook news page, Twitter account, and Instagram that provides information. We have thousands of community supporters who engage with us through these platforms. We have website resources, including a host of information on sarcoma, from verified sarcoma centers to financial and social resources. And of course, we have our webinars, opportunities for the community members to learn and engage with sarcoma experts. For our support initiatives, we have our assistance grants, which reimburse cost of second opinions, including travel, co-pays, lodging, all kinds of different things. And we grant up to $500 each. In 2019, we administered 84 grants. We also have, for over 15 years, ran a peer-to-peer program that connected sarcoma patients, survivors, and caregivers with others to really build those relationships and not feel alone. We have now partnered with the nonprofit Emmerman Angels, who specialize in one-on-one support and have expanded their program to include those facing sarcoma. We also have resource navigation. We receive over 2,000 requests each year for assistance in accessing appropriate health, social, and financial programs and services, where we provide one-on-one support. And then finally, connection initiatives. We have our Facebook support group. Currently, we have over 10,700 members on the support group. Really gives people an opportunity to connect with others who are facing similar experiences and diagnoses. We also have the Sarcoma Exchange. This year, we will be hosting our 3rd annual Sarcoma Exchange conference online because of COVID-19. And that will be happening in early October. The exchange provides sarcoma survivors, patients, and their loved ones, specialists, and other experts to connect in real life. Not this year, we want everyone to stay safe, but it will be online to exchange resources and learn really the latest in the sarcoma world. And then finally, our social media. Our social media accounts also provide another platform for people in the sarcoma community to not only see what we're up to, but to connect and engage with one another virtually. So how to get involved? It is Sarcoma Awareness Month. So one of our initiatives that we use to both raise awareness for sarcoma, but also to involve people in our community is to encourage everybody's participation in Sarcoma Awareness Month, which is July. During this month, you could challenge your friends to donate and share resources, use your talents to create jewelry, food, art, to raise awareness and funds for the Alliance. Seeing people get really creative, so thank you. We also have printable signs on our website that you could decorate your home or workplace with. You could even go as far to ask local airports or buildings to light up in yellow in honor of Sarcoma Awareness Month. People have given out sunflower seeds with a little note about the Alliance to raise awareness. They've organized events and concerts, and of course you could wear yellow outfits, makeup, hats, shoes, or sarcoma t-shirts to celebrate the month and raise awareness. We also have some Alliance branded masks that will be coming soon. We'd like your feedback on your favorites. More details about how to vote for your favorite will be coming soon. The suggestions really listed on this slide are not exhaustive, and we've got plenty more on our website. If you just head over to Get Involved tab of our website and click Sarcoma Awareness. So you can get involved with our organization really by donating online, hosting your own fundraiser, even on Facebook, or volunteering. We're always looking for people to share their stories, start a support group in their own area, write an educational article, compile resources, and serve in a leadership capacity. So please don't hesitate to reach out if you'd like to get more involved with what we're doing as an organization. So thank you, thank you. Here's the contact information where you can reach us. Now I'm happy to introduce our physician speaker for today's webinar. Dr. William Tseng is a sarcoma surgical oncologist and associate professor of surgery at the University of Southern California, USC, Keck School of Medicine. He was recruited from the University of Texas MD Anderson Cancer Center to help develop the sarcoma program at USC. Dr. Tseng has also served on the Sarcoma Alliance's medical advisory board for the last 2 years. Dr. Tseng has expertise in the surgical management of adult soft tissue sarcoma of extremities, trunk, and abdomen. He believes in combining different treatment methods, surgery, systemic therapy, and radiation therapy when appropriate to each patient's individual situation, really to provide the best long-term outcome. In addition to treating sarcoma patients, Dr. Tseng is actively involved in research and collaboration for this rare disease, and his efforts are currently focused on liposarcoma and RetroPeritoneal sarcoma. Welcome, Dr. Tseng.
Thank you. Okay. Great. Thank you again. Thank you, Alyssa, for that introduction. It's a pleasure and an honor to be here. I'm hoping to use the rest of this time to talk about soft tissue sarcoma to make this educational for everybody. And then I've incorporated some of the webinar registration questions into my slides. And then at the end, I also left some time so that we could answer some other questions that that were also brought up. So as Alyssa mentioned, I'm a surgical oncologist at USC. I'm an associate professor at the Keck School of Medicine. And I highlighted there that I do see myself as a sarcoma surgical oncologist. And I say that because I don't see or treat any other cancer. My practice at this point is, and for the last few years, has been 100% sarcoma. So just some disclosures to start off. I don't have any financial disclosures. I am on the medical advisory board, and I do also volunteer for a Facebook page. It's a Q&A page that I'm a medical consultant for. So to give you a little bit of background, just so you guys know who I am, in terms of my medical background, my professional background, I went to college and medical school at Northwestern in Chicago, did my surgical training at UCSF, and then went to Houston to MD Anderson. And then in 2014, I came to USC, was recruited here to try to develop and build our sarcoma program. So I've been here about 6 years, going on to almost 7 years now. Just so that you guys know, I do have other things in my life as well, other important people. And this is what, yeah, I'm indebted to, that's my wife, Mary. She's been with me on this whole journey from San Francisco to, and then that's my son. He's 3 years old, very curious boy, Preston. And then my dog also. He's also been very supportive in the last few years as well, since we've had him. And then if you guys are curious to learn more about what I do have my own business page or professional page, Liposarcoma Specialist on Facebook, and then Instagram page, Sarcoma Surgeon. These are meant to be educational, and they also do highlight the disease and kind of give you an idea of how I see the disease from my perspective as a treating physician. So to start off, what is sarcoma? Sarcoma is cancer of the flesh, and it's divided into bone sarcomas, which are mostly seen by orthopedic surgeons. I won't be addressing bone sarcomas in this talk. And then the majority of sarcomas, though, are soft tissue sarcomas, which is what I focus on and which is what this talk is going to be about. And what exactly is soft tissue sarcoma? These are cancers, and I emphasize the S there. We'll get into that, but these are cancers that arise in the soft or connective tissues of the body. So that includes the fat, muscle, vessels, fibrous tissue. And these aren't the organs per se, so it isn't, say, breast cancer or prostate cancer. Those can be, technically they're soft tissues, but this is more, it refers to more of the connective tissues. Our professional society for physicians and researchers involved in sarcoma is in fact called the Connective Tissue Oncology Society, or CTOS. Soft tissue sarcomas are rare. They represent only 1% of all of cancers in adults. That ends up being about 12,000 cases per year in the United States. And just for comparison, breast cancer has over 250,000 cases per year. So gives you an idea of how rare soft tissue sarcoma is. The cause is, for the most part, unknown. And when I say for the most part, there are exceptions, but for sarcoma in general, we don't know what causes them. And they also are not associated with smoking, alcohol, obesity, diet, lifestyle, or prior injury. I put a little asterisk there just to remind me that was actually one of the questions in the webinar registration, is if prior injury can cause sarcoma. And the short answer is not as far as we know. Soft tissue sarcoma can develop anywhere in the body. The most common location, though, is the extremities. And so that includes both the arms and the legs. It's actually more common in the legs than the arms. It also includes the retroperitoneum or the abdomen, specifically the back of the abdomen. That makes up about 20% of sarcomas. But they really can show up anywhere in the body. This gives you an example of sarcomas in different parts of the body. It also includes the breast, but it is, of course, different from the breast cancer that we all hear about and that we all know about. This particular example is an angiosarcoma that's usually radiation associated. And then I did want to emphasize an important point is that the symptoms can be subtle. Oftentimes there are no symptoms, and oftentimes it's incidentally discovered, or a patient suddenly feels that there's a mass that may have been there for quite a while and then starts growing. It often doesn't present with alarming symptoms like pain or something that you would go see a doctor for right away. So symptoms can be very subtle. The diagnosis of sarcoma depends on imaging and tissue. So in terms of imaging, that refers to radiology, or in more layman terms, X-rays. And that consists of either a CT scan or an MRI with contrast. Occasionally we do also do PET scans. There are certain situations, indications where we do a PET scan, but by far it's usually a CT scan or an MRI. And then in terms of tumor tissues, so that's what we refer to as pathology. So that prior to surgery is through a biopsy. Most of the time that's done with a needle biopsy, and that's just what it sounds like. That's when usually a radiologist inserts a needle into the tumor to get a sample of it to try to make a diagnosis. Every once in a while, we as surgeons, or me as a surgeon, do also have to get involved and do a surgical biopsy, which is a minor procedure, but it still is done usually in an operating room. In fact, I think it's almost always done in an operating room. But that would be to make a small incision and to surgically excise a portion of the tumor to make that diagnosis. I put it in gray there just because most of it, by far, it's usually a needle biopsy to get a diagnosis. So the tissue is the issue, or the pathology is key. It's another way to say it. And that quote, the first quote at least, is something that I remember from a pathologist that I had in medical school many years ago. And that's because soft tissue sarcoma, we mentioned, is rare, 1%, but it also is very complicated and very complex in that the classification, this is the WHO, World Health Organization classification. There are currently over 70 subtypes of soft tissue sarcoma, all within that 1% of cancers. And as I like to say, that soft tissue sarcoma is not just one cancer. I also published an editorial describing sarcoma and described it as similar or analogous to wine. And the analogy is that like wine, there are many subtleties, many nuances to wine. And for someone who is not a wine connoisseur, that person, whether it's a physician or whoever it is, may not know much about sarcoma, but for someone who is a wine connoisseur, they really know the subtleties, and those subtleties are important. And just as a disclaimer, I really don't know anything about wine myself. I really actually don't drink wine. But soft tissue sarcoma is not just one cancer. It can be multiple subtypes. These are the most common ones: liposarcoma, leiomyosarcoma, undifferentiated pleomorphic sarcoma, or UPS as it's abbreviated. I do want to point out that as we do more research in the field of sarcoma, we are finding that there are sarcomas, or the pathologists are describing sarcomas sometimes based on just their genetic change. So this is a good example. This is a genetic translocation called KMT2A. And in fact, I just saw a patient in clinic recently with this diagnosis, and that is the diagnosis. There is no other name for it. It's described by the genetic change. And so all of these different subtypes are backed, or not all of them, but for the most part, all of them do have distinct genetic abnormalities. Most of these are translocations. What that really is it's just, it's a part of the chromosome, the DNA, that breaks off and then joins with another part of the chromosome. That is abnormal. That is abnormal, and it's unique to just the tumor cells. And those specific translocations are unique to the specific sarcoma. So what does this all mean in terms of clinically and what we see in patients? So the different subtypes described by the different genetics, it does translate into distinct tumor behavior. So on the left-hand side are subtypes of soft tissue sarcoma. On the right-hand side here are unique tumor behavior, and you can see it's very specific. So for example, if you have a desmoid tumor, and you know, and you're confident that it is that diagnosis of desmoid tumor based on the pathology, that desmoid tumor will never metastasize or spread. Metastasis is spread. The other thing I wanted to point out here with the asterisk is lymph node metastases. So in contrast to other cancers like breast cancer, melanoma, colon cancer that do go to the lymph nodes, the vast majority of soft tissue sarcomas do not go to the lymph nodes. There are exceptions, and these are the exceptions that are listed here. So for pretty much all sarcomas, despite all that heterogeneity and the diversity of different subtypes, just generally speaking, for all sarcomas, if it's localized disease that has not spread or metastasized, the treatment is surgery. However, I would say that, I mean, myself as a sarcoma surgeon, that the surgery really is a balance of technical factors and disease biology. What I mean by disease biology is an understanding of the disease, understanding of the sarcoma, how it behaves, what we expect, how we expect it to behave, its prognosis, whether it's going to invade into organs or just touch up against them, and then of course the subtype. It's a recurring theme in this talk, of course. But it really is a balance, and then as you could see with this figure that I have, I would say that most of the time the technique is important, but most of the time an understanding of the biology is probably a little bit more important than the surgical technique. And then if you guys are interested, I was profiled in a Business Improv article about sarcoma surgery. I think it was an interesting look at how I approach, how sarcoma surgeons approach these operations. Taking a step back, so even though we said surgery is the main treatment for localized disease, for sarcoma just in general, there is often a role for chemotherapy and radiation therapy. As we said, most patients it is surgery alone, but in some patients we do chemotherapy and radiation prior to surgery. That's called, in medical terms, that's called neoadjuvant therapy. In other patients, we do surgery, and then after surgery, do chemotherapy and radiation, and that's called adjuvant therapy. And then occasionally, we do have patients, even with localized disease, where if we know the disease biology, know the subtype, know how it's expected to behave, if we think that it's going to be very aggressive, very high risk, we actually just do chemotherapy and may never get to surgery, unfortunately. It is a very complicated decision-making. There is a lot of complicated decision-making that goes on with each and every individual sarcoma patient that we see. And that's just inherent to the disease, I think. One thing I did want to point out, coming from MD Anderson, we kind of have a little bit of a bias there, I'd say, and that's that instead of saying chemotherapy, we tend to say systemic therapy. And I do agree with that in the sense that I think it's not just about chemotherapy. What's good about what we have available, the treatment options are that it isn't just the traditional chemotherapy where patients lose their hair, where they get really sick. We do have better drugs that are not, that don't have as many side effects. Some of these are targeted therapies, immunotherapy. And then the one thing to emphasize is that the treatment is very multidisciplinary. You could see that not only is a surgeon such as myself involved, but medical oncology, radiation oncology. It's very much a multidisciplinary team effort. And that's what I was about to say, is that it is very much a team effort with all the different disciplines. And that also includes radiology and pathology. That previous picture, I honestly just took that off of Google somewhere, so I hope I didn't violate any copyright with that. But this is a real picture of our multidisciplinary sarcoma tumor board at USC. So one of the questions that often comes up is, are outcomes better with a sarcoma specialist? I think for this audience, it may be intuitive, but the answer is yes. And this is some of the data to support it. This was just published in 2019, a very large study from France with over or almost 36,000 patients. And the gist of the study is basically saying that the answer is yes, overall survival is higher if patients are treated within these sarcoma centers or if they see a sarcoma specialist. And I've even had the privilege of writing an editorial about this. I did this with my colleagues from around the world. That's Rafe Pollock in Ohio, Alessandro Granchi in Milan, and Sylvie Bonvalot in France, in Paris. This was just published prior to this whole COVID situation in the Journal of Surgical Oncology. And what we did as a group is we actually came up with a definition or a criteria for a sarcoma specialist. And I think this is important on many levels. And for you guys as patients and family, I would encourage you to look at this. And if I may say, I think if the person that you are seeing, I think should be kind of evaluated with these criteria, these standards. So with that, I also wanted to recognize you guys, the patients and the family, because for sarcoma, I treat this disease as a physician, and obviously I see it every day, but I don't know what it's like on the other side, so to speak. So I put this together because it would, in my experience with all the patients that I see, I think sarcoma for the patient is it's rare. So most physicians that are seeing the patient don't know that much about it because of the different subtypes, and also because it's rare, it becomes very confusing. Unfortunately, this leads to a lot of misinformation. I can tell you that in my own clinic, when I see new patients, oftentimes I do end up spending a full hour, and that really is a full 60 minutes talking with the patient, just because of my goal to try to get that patient to really understand the disease to the extent that they want to understand it. It was, as we talked about in the beginning, sarcoma does also have a very subtle presentation a lot of times. It can be a painless mass, or it can have no symptoms at all. And these are also large tumors. They can be very large tumors. They can be very invasive, involve critical organs and structures. And so I think for the patient, sarcoma is very scary. As we kind of alluded to, and as you guys probably know, sarcoma can be very aggressive. Now, there are exceptions to that. There are sarcomas that are very indolent, slow growing, do not spread. But as a whole, sarcomas can be very aggressive. And then certainly with the disease itself and with the treatment that we give, whether it's surgery, systemic therapy, radiation therapy, I know that sarcoma is life-changing. And I know it is a diagnosis, a disease that for many patients, even after treatment, it stays around for a while, unfortunately. So having said that, I do think there are things that we can do to fight together against this disease, against this rare cancer. Education is one of them. There's always internet, Google, though I would caution that you kind of have to take that with a grain of salt, and depends on the source that you're looking at, may or may not be accurate. There's also social media. As I said, I have my own pages, and those are meant to be educational. And then referral to a sarcoma specialist, as we've talked about. And then I think support is of course, it's very important. And for that, I think Alyssa and, well, I thank Alyssa for all that she's done, and for Sarcoma Alliance, it's been a great effort, a great resource for everybody. And I'd say we should and will always continue to fight on together. So with that, I thought I'd shift gears a little bit, and we'll answer some webinar registration questions. So the first set of questions is going to be focused on retroperitoneal sarcoma. One of the questions that was posted is, how do you manage retroperitoneal sarcoma? We hear conflicting opinions. A similar question, a little bit more complicated. It says, my mom was diagnosed with retroperitoneal liposarcoma. She had surgery last year and biopsy results went out saying the margins are not clear. The doctor advised chemotherapy. After 6 cycles of doxorubicin, the CT scan was done and another mass is growing. So the doctor advised another cycle of chemo to stop the growth. My question is it really possible to stop the growth of the mass? And what is the possibility for it not to come back? There's a lot of features to this, or a lot of parts to this question, and I'd highlight some, and I'll address these. We'll talk about staging for sarcoma. We'll also talk about margins for retroperitoneal sarcoma. And then, of course, the ultimate question is it possible to stop the growth, to prevent recurrence, to prevent it from coming back? So talking about staging, for taking a step back, talking about soft tissue sarcoma in general. So staging in soft tissue sarcoma. We do have the same staging system that's used in other cancers, breast cancer, colon cancer, prostate cancer. It's the AJCC TNM staging system, and currently it's the 8th edition. I will say though that we don't really use it. And part of that is because it doesn't really apply to, well, I shouldn't say it doesn't really apply. I think that my colleagues who were involved in creating this would be upset with what I just said. It's not that it doesn't apply, it's just that it doesn't recognize things such as histologic subtype, and we have other tools, which I'll show you momentarily, that we think as sarcoma specialists, we tend to find those other tools more useful. One of these tools is the Sarculator, and this is something that it's a free application. It was created by my colleagues and friends in Milan at the sarcoma group there. It's a free application, so you can download this right now if you wanted to. And what it is you register, or you can be a guest user, and it's focused mostly on retroperitoneal sarcoma and extremity sarcoma, again, soft tissue sarcoma. And what it is you enter in data from that, such as age, tumor size, the grade of your tumor, and then the histologic subtype, and then you press the calculate button, and it actually gives you a projected overall survival at 5 years, 10 years. It's different for each of the different categories in terms of primary versus recurrent and versus extremity. And this is all based on data, based on published data. So it was all incorporated in. They did a great job of doing this. So we as a field, as sarcoma specialists and as clinicians treating sarcoma, we tend to use these kind of tools and these predictive tools more so than the staging system, I would say. So getting back to the question about retroperitoneal sarcoma. So just to get everybody on the same page. So the retroperitoneum refers to the back of the abdomen. And as you could see, this refers to the area around the kidneys. The kidney is part of the retroperitoneum. And that's where you can find tumors that can be pretty big, actually, but these sarcomas are would develop in this part of the body, retroperitoneal sarcoma. Retroperitoneal sarcoma, I'd like to say, is a different beast. And this is a very extreme example. A very large tumor, as you could see. And this case was actually got a lot of publicity after we removed the tumor, and the patient did very well. That got a lot of publicity in the New York Times and Washington Post. But I also think from a scientific standpoint, and I guess there's sort of curiosity standpoint, these are probably the largest tumors in the human body. Retroperitoneal sarcomas are, as you know, it's a subset of soft tissue sarcomas, so it's even more rare. It makes up 20%, so that translates into 0.2% of all cancers in adults. Tumors are larger. The diagnosis is usually established with the CT scan, not an MRI, and we often do a needle biopsy. Not always, but needle biopsy is part of the diagnosis. And then importantly in the retroperitoneum, as opposed to all of the 50 to 70 different subtypes, the more common ones that we see are predominantly the liposarcomas, well-differentiated, dedifferentiated, and leiomyosarcoma. There are a few other ones, but they're predominantly liposarcoma. The treatment is much more challenging than sarcomas at other sites. The outcomes are unfortunately worse. That may be both related to the complexity of the surgery as well as to the disease itself, the disease biology. And the major issue, as alluded to in that question that was posed, is that these tumors keep on coming back, or the tumors have a high chance of coming back. Secondarily, they unfortunately do keep on coming back. So that is called recurrence. So the major issue is recurrence in retroperitoneal sarcoma. The treatment is still surgery for localized disease, but that is what these tumors can look like. And what you're actually looking at is the patient's abdomen opened at the time of surgery. I apologize for those of you who are a little queasy. But this tumor extends from basically, it occupies pretty much most of the abdomen from the bottom of where the heart would be to the bladder. So you could see that these, just looking at it, just a very big tumor, very tight space. It's a very difficult surgery to do. And then getting back to one of the question that was posed. So without even any medical or surgical training, I would ask you, what kind of margins would you try to get for this? Because in order to get it all out and get clean, healthy tissue around it, you pretty much have to, unfortunately, take out a lot of things. So the margin situation is controversial within our field, within even our smaller subfield or smaller circle of retroperitoneal sarcoma surgeons. There's controversy about whether to remove additional or to do a more extended resection. That's something that's advocated by the Italians and the French and the European sarcoma centers. And that's even if it's not involved. And all of this is to try to get as much of a quote margin as you can to try to reduce the rates of recurrence. What we're finding in our field, and this is published data, this is in fact 1,007 patients. It's the largest series of retroperitoneal sarcoma from 8 centers around the world. What we're finding is that the outcomes really depend on the subtype. So this is that balance between the technique and the disease biology, where it seems like the disease biology is just as important, if not more important. So what you're looking at, different color curves, and each of those different colors represent one or a different subtype of retroperitoneal sarcoma. And so you could see that the recurrence rates for well-differentiated liposarcoma are very different from leiomyosarcoma. In fact, they're much higher, whereas in leiomyosarcoma, it's after surgery, it's a fairly low recurrence rate. So this is recurrence, local recurrence, the tumor coming back in the same location. However, oh, and then I did want to point out that unfortunately, there are sarcomas, subtypes of sarcomas. These are dedifferentiated liposarcomas that, and especially the high grade ones, that can have a recurrence rate of up to 50% at 8 years. So that means after surgery, after complete surgery at a sarcoma center, after good complete surgery, in 8 years, half of the patients will have some recurrence. Getting back to that point about how the outcomes depend on subtype, that previous slide was looking at local recurrence. This slide is looking at distant metastasis. And when you look at those two subtypes that we highlighted, they're pretty much flipped in terms of distant metastasis. So how you look at this is after surgery, leiomyosarcoma has at 8 years about a 50% chance of distant metastasis, whereas liposarcoma pretty much does not metastasize. We know that. And in fact, I should say that it doesn't. I should just say that it does not metastasize because that's pretty well established. So the question often becomes, are there other treatments? And the surgeries that we do for this particular type of sarcoma, retroperitoneal sarcoma, are very complicated. the outcomes in terms of recurrence, unfortunately, are not that great. So we do need better treatments. So what other treatments do we have? Radiation therapy. And does that help patients? If you look at retrospective studies that have been published, the answer would be yes. However, if you really look at those studies and analyze them scientifically, they do have some bias in them. So they're not great studies. Well, I shouldn't say they're not great studies, but there's some bias in them in the way that they were designed, the way that the patients were enrolled. And what that really translates into is we don't really know if you can really trust that data to say that radiation therapy is beneficial. We do have a prospective study that was presented at ASCO, which is our annual cancer meeting last year in 2019. And prospective studies are better than retrospective studies. They don't have as many of the biases that we just talked about. So that data that was just presented last year, not published yet, shows that radiation therapy, well, for all retroperitoneal sarcomas, there is no benefit, but there might be a benefit for liposarcoma. It's still kind of unclear. Systemic therapy or drug therapy, well, this is some work that I have been doing myself for the last few years in collaboration with other sarcoma specialists and centers around the world. And we just presented this data at that same meeting, ASCO. It was a virtual meeting this year, last month in June. And this was a retrospective study, so it does have the biases that we talked about. And it's a little unclear. We're still studying this to see if it is beneficial or not, and possibly in high-risk patients, it is beneficial. So one or several of the questions on the webinar registration were also about other therapies besides radiation systemic therapy. And they do exist, and many centers are looking at them and trying them and evaluating them. These include intratumoral injection. So you take something, whether it's a chemotherapy agent or something else, try to inject it into the tumor. Another option is to try to ablate it, which means that you put in a probe and either heat the tumor or freeze it. That freezing part would be called cryoablation. There's other things that we're looking at, but nothing is really established yet, unfortunately. So it still is surgery for this particular type of sarcoma. So the next question that I wanted to answer, next group of questions, is about liposarcoma treatment. These are a couple of examples. Are there any new treatments for various liposarcoma that are proving effective? And what are the most effective targeted therapy drugs for retroperitoneal liposarcoma cancer recurrence? How long are these drugs effective? And just to get everybody on the same page, so this is liposarcoma is one subtype of all of the 50 to 70 different subtypes of liposarcoma. But even within liposarcoma, there's 3 subtypes, if you will. And these are listed on the left there: well-differentiated, dedifferentiated liposarcoma, Mixoid liposarcoma, and pleomorphic. They each have distinct genetic changes. That gets back to the slides in the beginning. But they each have distinct genetic changes that define it as, say, a well-differentiated, dedifferentiated liposarcoma versus a Mixoid. They also have, as expected, distinct clinical behavior. Well-differentiated liposarcoma does not spread, whereas pleomorphic has a very high rate of distant metastasis. And they also have different responses to therapy. So the questions that were posed in the webinar on the previous slide, the webinar registration, it kind of depends on what liposarcoma you're talking about in terms of the response to therapy. And then getting back to our theme, that pathology is really key. Knowing the pathology based on how it looks under the microscope and the genetic changes is key to say what type of liposarcoma you have, and then what type of clinical behavior, what type of response to therapy. But getting back to this question, so I put together this slide just in the last couple of days in preparation for this talk. And I do want to say one disclaimer, disclosure, is that I'm not a medical oncologist. This is a little bit, it's a little bit like asking a medical oncologist to talk about surgery. So that's my only disclaimer, but this is as far as what's reported in the medical literature. And of course, how our medical oncologists and other sarcoma medical oncologists around the world treat this disease. And then I do also want to say that when you're thinking about systemic therapy, it is important to think about the goal of therapy. The goal of therapy means, what are you trying to achieve? So surgery is obviously you remove the tumor, but for systemic therapy, it does not remove the tumor. So when I say goal of therapy, it's referring to, are you trying to stabilize the disease, keep it at bay? Are you trying to shrink the tumors? Are you trying to get rapid shrinkage of the tumors? Or is the patient symptomatic and you need to do something, but you can't do surgery or radiation? So that's the goals of therapy. And I think that's important to keep in mind when you're choosing with your medical oncologist systemic therapy. But getting back to the different subtypes, so well-differentiated, dedifferentiated liposarcoma, and most of these therapies are actually in applied or more effective for dedifferentiated liposarcoma. That's why it's in red there. But first-line therapy is adriamycin and ifosfamide. And then these are some of the second-line therapies that are out there. Eribulin is a drug that's actually FDA approved for liposarcoma. Interestingly, it's a drug that's derived from the ocean. It's a marine, M-A-R-I-N-E, marine-derived drug, which I think is kind of interesting. There's also CDK4 inhibitors, and CDK4 is a target within this type of sarcoma. And so that's kind of the beauty of this type of treatment, and this is why it's called targeted therapy, because we know that this type of liposarcoma overexpresses this particular molecule called CDK4, so we can inhibit it with a drug. So that is being used in the treatment. Anti-PD-1 is a type of immunotherapy. Immunotherapy in a nutshell is trying to get the patient's own immune system to attack the tumor, to attack the cancer cells. And then there's also third line and other clinical trial type of drugs like selinexor and MDM2, which is another targeted therapy. You don't have to remember any of these. These are all things that the medical oncologist should be talking to you about in terms of the different options. But I just wanted, the whole point of showing you all this is just so that you guys can get familiar with the names of these drugs and the abbreviations like AI. And it's also more for me to try to convey that there are many different options that are out there that we as a field in sarcoma are trying to explore for the treatment of this disease for liposarcoma. And then it keeps on going on. I should have finished before saying what I just said. So there are other options such as single agent high dose ifosfamide. There's also Trabectedin, which we'll get to very shortly. I put that in green because that is something that's done more in Europe and specifically in Italy, in Milan. But I actually think they have some good data to support use of those two drugs in green for this disease. Okay, so that was one subtype, well-differentiated, dedifferentiated liposarcoma. And then for Mixoid and round cell, another subtype. So it is the same drugs, adriamycin ifosfamide, but here Trabectedin is starting to emerge as a very good treatment for this particular subtype. And then this subtype is also very sensitive to radiation. So there are studies, in fact, there's a published study, there's an ongoing study looking at the combination of Trabectedin plus radiation therapy. There's also work being done looking at a specific target, NY-ESO1, in myxoid liposarcoma, and this one in particular tries to leverage the immune system. So it is a immune-based therapy specific for myxoid liposarcoma. Pleomorphic liposarcoma, which by the way is much more rare than the other two subtypes. The treatment does also start off with adriamycin ifosfamide, but some of the data that we had for eribulin, if you actually really scrutinize that data, it's actually more effective for pleomorphic subtype. So with that, that pretty much concludes my presentation. I think I've kind of gone over a little bit in terms of time, but I'm happy to stay a little later as well.
So Dr. Singh, thank you so much, Dr.
Yeah.
Singh. Yay. That was really comprehensive and I think very educational for lots of folks joining the Zoom call. Can you go ahead and stop sharing your screen? And then we'll open it up to questions. Feel free to write your question in the chat. And then we have about 5 minutes before we'll close up, and then, but it looks like there are some really good ones coming in. So let's see, Will Schumann says, what are the issues regarding a curative surgery attempt to treat a first local? Can you see these, Dr. Singh, as they're coming in?
Where do I go
on the chat?
Yeah, I see the chat, but I don't know which one you're looking at. Maybe it'd be easier if you just read them.
Okay. To treat a first local retroperitoneal recurrence where a biopsy due to location is not possible, practically timing of such a surgery, how long should one wait to get a better understanding of tumor biology?
Yeah, this is retroperitoneal, right? Is that what they do? Yeah. Yeah, it's a great question. So sometimes if you cannot biopsy it, in fact, oftentimes at recurrence, we don't necessarily biopsy it. On the CT scan, you can tell based on what the original tumor looked like that it probably is a recurrence. You can tell if it's in the area where you did surgery. And then for liposarcoma specifically, what we look for, I'm talking about just on the CT scan, what we look for is whether there's a low-grade disease, low-grade component, well-differentiated, and a high-grade component. So you don't necessarily need a biopsy to prove that you have a recurrence when you're dealing with retroperitoneal sarcoma and retroperitoneal liposarcoma. And then how long should we wait to test the disease biology? That's a great question, and it's something that we're actually trying to study in the field, to formally study that. In my practice, and I think for most surgeons, sarcoma surgeons that deal with this disease, we tend to get CT scans every 4 to 6 months after surgery. And once we've found a recurrence, once we see a recurrence, what that question is referring to with test the biology is we don't always jump to surgery. And sometimes, especially if it's just low-grade disease, well-differentiated disease, we just watch it. And that's testing the biology of it to see if is it going to grow? Is it going to show up as more than one tumor? So to answer that question, we don't have a great answer, but it's still probably within, with CT scans every 4 to 6 months, and you reevaluate with each CT scan to see what's going on. If the tumor does start to grow, then usually you do need to, for the most of the time, you do actually need to do something about it, but not always. Sometimes if it's a minimal growth, you could still continue to watch it a little bit longer, maybe in 2 to 3 months, repeat a scan. So it's a complicated decision-making process.
Okay, and then I'm just going in order here. The next one's from Anna, and it's also a retroperitoneal question.
Okay.
If the tumor is inoperable and the patient can't have chemo or radiation, considering variables, age, lifestyle, etc., what are the symptoms the patient will have? How does the patient die? How does the patient what? Die. Die?
Yeah, it's a tough question. If it's inoperable and drug therapies are not an option, or we've already exhausted drug therapies, the tumor will continue to progress. And the growth rate of it does depend on, if we're talking about liposarcoma, it does depend on whether it's a low-grade or high-grade disease. The high-grade disease, the dedifferentiated disease, tends to grow faster. Low-grade disease, well-differentiated, tends to grow slower. It's not an absolute cutoff. There are well-differentiated liposarcomas that grow almost as quickly as dedifferentiated. And it's hard to say how long the patient has and when the patient will die. It depends on how much the disease burden is, how extensive it is, whether it's involving organs, which organs it's involving. The body does have a lot of resilience to adapt to these tumors, especially with liposarcoma. And then I think that the specific question was, how do they die? Is that? Yeah, you know, I have to admit, I don't really see the patients when they get to that point. I mean, I of course have had patients that do get to that point, but it's mostly patients get very malnourished. They have usually a very big abdomen by that point, where the tumor has grown in size. There's usually a lot of in addition to malnutrition, the patient can have ascites, fluid in the abdomen. Eventually, the patient can have bowel obstruction or bowel, it's called ileus, where the bowels don't really work, and it's not, yeah, unfortunately, it's not very pleasant.
The next question is from Christine. What is the best surgery for leiomyosarcoma, hysterectomy, full abdominal, or laparoscopic?
Yeah, that's a great question that I actually have to admit I don't really treat the gynecologic sarcomas, so I'm probably not the best person to answer that. I do see leiomyosarcoma when it's recurrent, and that's usually after the patient's had a hysterectomy. So I would say, though, that the laparoscopic part to it, there was part of that question was whether laparoscopic can be done. And it certainly can be done, but one of the important things with that is that you always have to make sure that the tumor doesn't get what's called morcellated. Laparoscopic means it's surgery through small incisions as opposed to one big incision. And gynecologists, when they're doing the laparoscopic operations for benign disease, not leiomyosarcoma, but benign disease like leiomyomas or fibroids, they often do remove the tumor, and then before removing it from the patient's body, they actually break it up into pieces. That's morcellation. And that, if it's a leiomyosarcoma, is absolutely bad. Like that is not the thing to do at all. So if your surgeon is, especially if your surgeon knows that it's leiomyosarcoma, can still do it laparoscopically, but there better not be any morcellation involved.
The next question is from Linda. How does an abdominal mesh impact a resection?
How does it impact what?
An abdominal mesh impact a resection?
Oh, it doesn't necessarily. Well, are we talking? Are we talking about that the tumor is involving the? Because mesh is usually, is it involving the mesh? I guess is what it's my question. Because if the mesh is usually put for, say, a hernia repair, it's usually like, say, the classic hernia is in the groin, or if the patient's had prior surgery and there's mesh, and the patient had a hernia with the front of their abdomen, that prior surgery, a mesh may have been put in to repair that hernia. So if the tumor is not involving the mesh, it's not a problem. We actually surgically, we just cut through the middle of the mesh. And usually by the time that we get to the surgery to remove the tumor, not to fix the hernia or anything, by the time we get to that surgery, the body wall has already remodeled itself so that you can essentially cut through that mesh and then suture it back together afterwards. It is, for us as surgeons, just as a little side note to kind of be funny, it does make it tougher because when we put in our stitches to close that area with the mesh, our needle has to be, I guess, a little bit sharper. We have to use a little bit more force because we have to go through not just normal tissue, but the mesh as well. But you could suture up the mesh back together.
And Dr. Tseng, I'm just doing a time check. I know we're over time. Do you have a few more minutes? Or?
Yeah, I have a few more minutes. Yeah.
Okay. And all right, the next question is, if a patient has RLMS that has been metastasized, can surgery still be considered, or is the systemic the best approach?
Is that LMS, leiomyosarcoma?
It says RLMS.
Yeah, that's probably retroperitoneal leiomyosarcoma. Leiomyosarcoma, especially in the retroperitoneum, does have a high rate of distant metastasis. That data that I showed you guys earlier, it's up to 50% after resection. Overall, it's probably about 50% before and after. Before meaning some patients will show up with the tumor in the retroperitoneum and distant metastasis. So in that situation, we do, as a field, we're starting to move more and more towards neoadjuvant systemic therapy for that situation. And certainly if it has spread, I guess let me clarify, if you've got a situation where the patient has retroperitoneal leiomyosarcoma, has not spread, we give neoadjuvant systemic therapy. We're trying to move towards that. If you have a situation where you have the retroperitoneal leiomyosarcoma and it has spread, then for sure you give systemic therapy first before surgery. And the question is surgery an option? Is that what?
Right. Can surgery still be considered?
It is a complicated decision to make, and it's one that's done with the medical oncologists, because I could tell you for our own practice at USC, what we're looking for is how many sites of distant metastasis and how the distant sites of metastasis are responding to treatment. So if you give the patient systemic therapy and the distant metastases, you had one lung metastasis to start off, and then on treatment, systemic therapy, there's 3 sites of metastasis, then that's not a good situation to be taking the patient to surgery. However, if you've got one metastasis and then after systemic therapy, you still have one metastasis and it's smaller, and maybe the primary tumor is smaller as well, then that's a good situation to consider doing surgery. Leiomyosarcoma, that specific subtype is one subtype that we're learning as a field, is one where you can go after metastatic disease surgically, both the primary site and the metastatic disease. And we're finding that in some patients with leiomyosarcoma, you can have a very good long-term survival even in metastatic disease. So even when it's spread, with the right surgery, the right systemic therapy, occasionally radiation therapy, the right timing of all of that, patients can live for a long time. In fact, I just saw a patient in clinic yesterday who was already 4 years out from her original surgery, even though it's spread to the other locations. And she still has distant metastasis, is doing great on drug therapy that's just stabilizing those lung mets.
Mm-hmm. Let's take a couple more questions, and then I apologize that we can't get to everyone's questions. They keep on popping up, but remember that you can reach out to Dr. Tseng at Sarcoma Surgeon on Instagram. So the next question is, when there's no hope for clear margin, can you negotiate ablation of organs such as the second adrenal or first one already taken? The first one's already taken, okay.
I didn't quite understand. So the adrenal is taken, or what?
Can you negotiate ablation of organs such as the second adrenal? I'm
not sure what that question is really referring to, but you can ablate tumors. That's an option to try. And in fact, I think if I'm correct about this, I think MD Anderson is trying to explore doing that for unresectable disease.
Okay. And then the last question we'll take is Mixoid liposarcoma, recurrence to the abdomen. Let's see. 18 months, then one tumor grew 4 centimeters in 4 months. Recent surgery removed tumor in abdomen and one unexpected tumor. Currently no sign of tumor. Would follow-up chemo be useful?
Yeah, It's hard to answer that without actually.
I think we're getting really specific questions.
Yeah, yeah. Well, I will say the bigger question is adjuvant therapy effective or useful in myxoid liposarcoma? And the short answer is we don't have great data to support it, but we do definitely do it. So it really depends on that individual patient situation. There are a lot of things that go into it.
Mm-hmm. Mm-hmm.
It does I think it does emphasize, just kind of maybe in closing, that it is important for everyone to be evaluated by a sarcoma specialist, not just the surgeon, obviously, but a sarcoma team, to go to a sarcoma center, because that's the kind of situation where you need input from a surgeon, medical oncologist, the whole team that knows about this disease, about myxoid liposarcoma or sarcoma.
Perfect. And that was a great way to wrap up, Dr. Tseng. Thank you so much. That list of sarcoma centers is available on our website, sarcomaalliance.org. So feel free to check that out. Thank you, Dr. Tseng,
yeah, thank you
for your presentation and answering the questions and devoting so much time to our community. So appreciate that.
Great.
All right. Thanks, everybody. Stay in touch. And the next webinar will be our sarcoma exchange, October 3rd through the 4th. And we'll be back here. Thank you. Bye-bye.
Bye.